Hey everyone, this is the Nips and Sips podcast featuring me. I'm Dr. Jeremy Boyd, my partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about chronic ankle instability and seeing where it goes. Maybe we'll talk about some other ankle issues or sprains. But before I get too much into that, how's it going, Brandon?
Going well over here, Jer. Thanks for the intro. For our audience, we might have touched upon parts of this topic in a previous episode, the foot and ankle, but we figured we'd dive deeper more into the chronic ankle instability. And like Jeremy said, and probably we'll go off into a tangent into some of the other types of ankle sprains. But Jer, what do you got drinking there today? Nice shirt, by the way. Our pink right there.
Yep, I represent. Today, I'm hitting Rooftop Chillin'. It's a little bit of a lighter beer. Still got some work to do after this. I had it from Ludlam Island Brewery. It's the first brewery I had since COVID or been to, outdoor dining style. So really cool. So it's real nice. We got some leakage. I got a sweet cup today from that brewery. So I've had this before at the brewery. It was pretty good. I'd give it 7.4. Just a nice kind of crushable drink. You can have a couple of these and it would be fine. So I think it would be good. What about you there, Brandon?
So what you're saying is your homemade beer is almost 2 points higher than this one.
Yes, I agree with that.
There's nothing wrong with that. That's fine. You should start selling yours out.
Right, and this is they're pretty one of the bigger named breweries. They're small, the brewery, but they their beer goes pretty far and well received. So, just saying, if they want to buy off my product, I'm all right with that. But 9.3.
I got my Noble Oak, the one I tried in our previous episode. I liked it a lot, so I'm back with it again.
Nice.
And
regular cup today, huh?
Yeah, ish. I mean, it's the one from the office. It's just a regular plastic cup. Nothing fancy there. But yeah. So anyway, moving on to our topic. Jer, I know you see more of an athletic population than I do now. I guess, what has been anecdotally some of your thoughts on diagnosing, treating conservatively chronic ankle instability or just ankle sprains in general. We could kind of probably tease out the two as we talk. And then I'll shed some light, I guess, on some of my thoughts afterwards. But where are you with it? How's your treatment evolved and everything?
Yeah, I think what you were just kind of mentioning, at least teasing out one or the other. If you really kind of listen to your client, stuff like that, most people probably, even though it's their first time going to PT for a lateral ankle sprain, they probably have some form of ankle instability or chronic ankle instability. They mentioned a couple of times you start, going through a subjective exam, like, oh, it rolled on me a couple times. It gives out here and there. So that's when I start to think, hey, this is something, that again is chronic. It's been going on for a little bit. So yeah, I do see a fair share of these. Obviously, from a pathoanatomical standpoint, stretching those ligaments from the sprain, especially the ATFL, you'd think, all right, yes, we need to stabilize the joint, which I, fully endorse. But, if you really take a look at it, and especially the ones that need physical therapy, let's face it, what do you say, Brandon? More than probably half of the people who have an ankle sprain probably don't ever go to PT, maybe more.
Yeah, I'd say it's more than that. I think. Let me see if I can find it here. I think it was close to 80%. 80 to 90% don't get referred. I have a presentation on that. You'll talk. I'll dig it up. See what I can find out.
So, for those individual, but most of the time, I mean, yeah, I get some acute ones. We're starting to establish ourselves with direct access. But for the most part, they're in either subacute or chronic phases. If you start looking at things, yes, again, pathoanatomically, they need to, strengthen up those ligaments and everything like that. But more often than not, they're restricting their range of motion. And what really makes a difference is, mobilizing their stiff yet unstable ankle. So, those are some things that I, see clinically. But go ahead, Brandon. I don't know what you have on the other end there.
I was just going to ask you for our audience, can you kind of dive into that? Stiff but unstable. Usually people think instability is lax. So yeah, just dive into what you mean by that. I think that's a great talking point.
Yeah, I mean, a lot of people, can perceive either from dislocations or ligament ruptures or ankle sprains. It's like it's unstable or it's loose, or that would be excessively hypermobile. We want it to stiffen down some bit and, just kind of, focus on, the strengthening side, balance, whatever it may be. Sorry. But in reality, if you, get your hands in on, the joint itself or the client, feeling the tone of the tissue, you'll start to see that things are anything but loose. If you're finding out, I look to give the best, most effective, easiest treatment. Putting my hands on people, that takes time. I can easily see two people by just giving them exercises. But with that, if you put your hands on ankles, especially in the case of like a chronic ankle instability or just a post-lateral ankle sprain, you'll find that, if you're really breaking down the specific joints of, talocrural, subtalar joint, calcaneus, on tibia, you get your everting, inverting, midfoot, and those sort of things, you will find most likely some stiffnesses. So, it behooves you to address those, because more often than not, people will work around those stiffnesses, and that's going to cause all kinds of dysfunctions and issues. So that's kind of how I perceive it. What about you, Brandon?
Yeah, so I have the research here talking about it. So you're right. It's 50% don't seek treatment, but that's medical treatment in general, not just, physical therapy. And that stat, where did it just go? Here we go. That's by Williams and Bayon, two different studies, one in 2005, one in 2001. 80%, where I got confused, 80% re-injury rate.
Oh, that sucks.
So
that's awful.
That's awful. And I mean, I'll attest to it. I played basketball growing up. That was my main sport. I sprained my ankle. I didn't go to the ER or even PT. When I was younger, it was just ice it and kind of, wrap it up and play through it. When I got older and when I sprained it actually a couple years into being a PT, I had my coworker just manipulate my foot, and I did some exercise on my own, and I was pretty good to go.
You still play basketball, right?
Yeah, I took a few years off, but that was more work related, not injury related.
Yeah.
Work life, starting a business related. But yeah, now I play. I'm fine. Knock on wood. I haven't had an injury or sprain or anything in the couple years I've been playing since. So, but yeah, I mean that's alarming. 80% re-injury rate, and we have to ask why. And I think you were pretty much alluding to it. We get termed ankle sprain, so we think pathoanatomically, or at least what we're taught in school. Okay, the ligament is torn or partially torn or completely torn and lax, whether it's the ATFL, the CFL, both, or even the whole complex. And we think simply, okay, we're just going to strengthen the everters. But what aren't we assessing? What are we missing? And it goes to that talocrural joint, limiting dorsiflexion, even limiting possibly plantar flexion. Your body is just going to try and diminish as much range of motion as possible to keep it stable. That's a neurophysiological subconscious thing that happens where your body's just trying to, protect itself. And then, as you said, how does now the subtalar joint respond to that lack of dorsiflexion? Does that become stiffer or more mobile? The midfoot, the cuboid, the navicular joints, so we have to look at that whole complex, even the great toe, lacking great toe extension. I mean, these are all things I've seen, especially with people who have multiple sprained ankles, where that whole foot just becomes stiff and rigid. I had a runner, he was like one of those like rucksack runners, where they like run for like 8 hours or 24 hours with like a Tough Mudder type thing. Yeah, all that stuff. And he's like, I don't even know how many times I sprained my ankle, and his whole foot just moved as one. Like there was no dissociation, there was no forefoot, midfoot, rear foot dissociation like there's supposed to be. So now, you have a rigid, basically he had a paddle, and if it went the wrong way, he was rolling. So, with some manual therapy, we definitely created some dissociation, improved the joint mobility, and then we added some exercises to kind of, make everything stronger and reactive. And I'll touch upon that in a second. But when you're looking at exercises, Jeremy, are you just attacking the foot ankle complex? We talk a lot about regionally. Do you go to the knee? Does the knee need to be treated, or can we just skip to the hip, pelvis, low back? What are your thoughts on that?
Yeah, no, definitely just can't keep it to just the ankle. I mean, even that's, unless someone took a bat and somehow whacked your ankle into a sprain, it's something probably up the chain failed to assist that ankle kind of rolling in. So I typically, I look at, rotations into the knee, just quick, in my assessment, make sure the knee can actually function. I rarely see a lot in the knee that can, from a strength wise, sometimes proximally like the tip fib and again, those rotations can impact the ankle from a manual therapy or mobility issues. So I attack that up there. But a lot of, issues, especially mechanics and form wise, and where are they getting their balance or control from? Are they using, trying to use the ankle strategy as their primary, stability, or they're using appropriate like kind of hip strategies? So more often than not, especially in the athletic population, or really in anyone, I always say the athletic population, but it happens a lot in your standard people as well. They don't have a good, hip or, core control at all. Not the greatest muscles up there. So yes, could you in theory fix people just by hammering home that ankle, and probably make them better? Sure. But that's when it, can reoccur, because you never truly address what was missing in the whole chain there. It's like a weak glutes, and causes changes at the knee and to the ankle and all that sort of stuff. So yeah, I try and hit it from, top down, kind of approach from there. Again, as we've talked about in previous things, we a lot of benefit treating proximally than to distally. So what about you, Brandon?
Yeah, I've noticed, especially when you're talking, well, I was going to say athletes, but let's back down. Like, right? When do most people have ankle sprains? It's like stepping off a curb or stepping on like a little like ditch in the grass or something. Obviously, let's say basketball, landing on a foot or going to stop. Volleyball. So they're decelerating. Volleyball, same thing. They're coming down. Actually, I'm working with a professional volleyball player now, and she's had some ankle sprains, but all the way up the chain, we're actually treating her for her hip / low back. Those glutes just they're not as strong as they need to be. You have someone who's 6'5", jumping 100 times a game and landing on one leg. That one leg needs to be able to control over 200 pounds when you include momentum down on one leg. And that's, eccentric and deceleration. And if that hip isn't there proximally, you're either going to go into a valgus position at the knee or inversion at the ankle. Being able to strengthen proximally, work on functional training, functional movements, landing patterns, things like that are definitely going to be more so. And honestly, I hate to say it, most of my treatment is at that pelvic and hip control. Maybe I'll do a little eversion, inversion, or dorsiflexion with the TheraBand, just to kind of get some motor control, and maybe get those muscles just kind of working the way they should be. But most of it is being able to land, have a sense of awareness, and I kind of let my manual therapy kind of revitalize those proprioceptors that are there, and just to close kinetic chain exercises do what they need to do. Because when you look at an ankle sprain, it's not just the ligaments or the muscles, the tendons that are being damaged. It's all the proprioceptors that affect balance. And those proprioceptors are within the joint, they're within the ligament, they're within the tendon and muscle. And when there's a rip, quote unquote, or a tear or trauma, those proprioceptors are being altered. And I find that some of the manipulations, which is has a lot of neurological or neurophysiological effects that control alt delete, as well as even your MWMs and even your weight bearing dorsiflexion mobs, and progressing that way, it's going to give some centration to that joint and kind of work that feed forward loop of hopefully revitalizing some of those receptors in the ankle there.
Yeah. First of all, I love the control alternate delete reference. You want to talk about that real quick, and then I want to talk about your glutes and your firing and a little bit more about that. But you want to bring that up for people who are like, what the hell did he just say? Control delete. What do you mean by that?
Control delete. I believe I got that. Was that Bill or Scott? I mean, I think that was the first time I heard it during residency. And we talk about this in our courses, just the physiological, neurophysiological mechanisms that are going on. It's a reset to the brain, or the brain and body. If you look at neuroanatomy and the first and second order responses that go up to your motor cortex and your periductal acrograe and your pain centers and your rostral, ventral, medial aspects of the brain, they will control movement or motor control and pain. So if you're able to provide a quick thrust that's affecting those proprioceptors, it's going to create a descending inhibition for kind of pain. And it's kind of the analogy of what we do to our computer when we're frozen or something is we either restart it, or I think on the old computers there's Control Alt Delete, right? Is that what restarted the computers there?
Old
so I have a Mac
computers.
now. I have a Mac, so it's just you hit the force quit button. I guess it's probably the same thing.
Yeah, I don't know what happens if a Mac is to permanently to freeze. I don't even know if there's an on-off button on this bad boy.
I press power for 5 seconds until it turns off. Cross my fingers that everything's still there.
Hope the battery just runs out. But no, that's a good way to look at things with that. Quick reset. But yeah, you mentioned something about glutes and again treating proximally. If you're when I look at athletes and those sort of things, and again I always kind of say, probably talked about it, sucks that you had an injury, but let's make you a better athlete, or just make the person a better person. They don't have to be an athlete. But the goal is to get people as independent as possible, not needing therapy. And no one really wants, those frequent flyers. So especially with ankle sprains, it's, again, anybody can fix something locally, but to kind of prevent it from happening again. And we're talking about like glutes and taking a good assessment of people. Sometimes I see with athletes, with either ankle sprain or a knee injury or something like that, and they lack the ability to extend their hip past neutral. They only get like 30 degrees. It's just straight in line and those sort of things. And we can't really fire up the glutes efficiently unless we get all like that terminal hip extension. Just like the knee, we don't talk about it as much in the hip, but you can't, like with post-op ACLs, if they don't get full extension, those sort of things, can't get the quad to go. Same with the hip. You can't get that glute max fire unless you get all the way. And then we're talking about performance and those sort of things. We talk about triple extension and everything like that. If they're not able to do that, if you're not addressing that, one, they're losing power, but two, where are they going to generate the power to jump, to land, all those sort of things? It's going to be probably somewhere down the chain, and that's where they're going to get hurt. So,
up the chain,
yeah. The
like
up chain, yeah.
Rotations
and stuff like that.
Yeah, TL junction stuff.
Yep. So that was a good point there.
Yeah. What are your thoughts on? I guess I have some stuff here, but surgery. When does this population need surgery versus not? Obviously, our bias is to avoid surgery at all costs, but obviously there are people who need surgery, and what types of surgery are they typically getting? Any thoughts for our audience out there on this one?
Yeah, so I've been, again, kind of lucky where I haven't had anyone have like a stabilization procedure, or at least not for some time. But if it comes down to it, it's when it starts to impact the quality of life. Same with things like those reoccurring shoulder dislocations. You've even heard people have had Bankart repairs and those sort of things. And when do you make the call to get like a ladder J procedure, a ladder J, whatever you want to call it? But you're talking like the Brunstrom and those sort of things. Is how many times is too many times, essentially. Especially, you're starting to get into those, all right, and not just little baby rolls here. We're talking about, we're seriously spraying where the point where they can't ambulate. We're starting to get like 3, 4, 5, those sort of things. It's every single time they have to be, either booted, casted, crutches, or it's this chronic pain, or again, it's limiting performance. Those are the sort of signs I would say, hey, and if you did obviously your due diligence, had thorough physical therapy, and then also on top of that, the client in between times was working on things. I was doing all my ankle proprioceptive stuff. I was trying to do this, and it's just so easy for it to keep spraining. Those are those signs I start to see. It's like, all right, if I had that, like, I want to refer to potential surgery. But Brandon, I know you've had a couple. What are your thoughts on all that?
Yeah, I've had a few. I mean, the research says conservative rehab is better than surgery, even better than just casting somebody. Actually, let me see if I have the article. Kerhoff's 2009 looked at that they actually favored functional treatment over cast immobilization, and obviously conservative treatment over surgical treatment definitely lowered the cost as well. But I think unless you're somebody who's had like a wicked grade 3 sprain, and it's probably happened a few times, and that thing's just kind of hanging on there, and you really don't have too much control. And to go to the biomechanical explanation here, that it's not in that mortise. That talus isn't in that mortise. You have to be careful, because now you have run the risk of that person having like a anterior dome OCD lesion, because let's say we have the mortise here and the talar dome, and it's supposed to fit right in there nicely. But let's say they don't have those ligaments or that control, and they're out here, that anterior dome is going to hit into that mortise, and over time that's going to create a lesion. So unless you're a high level athlete, we're probably talking college and above here, I probably wouldn't recommend it, or at least try physical therapy, true amount of physical therapy before you entertain that. But yeah, someone in the pros or, high level college, and they need to, not keep missing time because of ankle sprains, they're probably just going to get the surgery. I'm okay with that. But then obviously when we get them on our side, we need to take care of it the right way.
Yeah, and I think it'd be a good time we'll start putting up some videos of some techniques, because especially post-op, whatever it may be, or a prolonged immobilization, they're in those cam boots or a cast for a long period of time, you can guarantee those bad boys are stiff. Take a normal human being and who didn't have an injury at all, and you slap them in the boot or something like that, just from the lack of movement, things are going to be stiff. So it'd be good. We'll put up some videos, but while I do that, I do remember I had recently, we didn't treat her. She just wanted to be assessed. She has the she's the national record for her weight class. She did like 300 something, and she weighs maybe 100 pounds or something like that. Deadlift record, like the natural, no juicing.
Raw.
And then, huh?
Raw is how the
raw. Powerlifting record in the USPA. I forget which association. There's two major ones. She's in one of them. But she was just asking about things. First messaged me for a while, and then I was treating her boyfriend, or now fiance, or husband. I was like, have her come in while I treat you. I'll take a look. And she was just telling me that she sprains it like all the time. And I was just looking at Taylor tilt though. The separation was even me. I was like, oh shit, like that type of look. Like you can see the tip of the distal fib like poking out. Like if I went a little bit further, just like poke right through the skin. It was like that much separation. I was like, that much laxity. I was like, oh shit. I was like, I told her, I was like, listen, this is, it shouldn't do that, especially how many weeks out she was. It wasn't like at that point she did it for, a week or so ago.
Yeah. So was she just naturally lax person? Did she have a lot of
no,
injuries?
Other side was fine. Like I assessed the other side. She's flexible, but she's more stable because she's such a good power lifter. But I told her I was just, huh?
Where'd that come from?
I can't remember all the other sprains were from. And
okay.
She's like, I've had histories of them, and this time she fell into a ditch in her backyard. Like she just, and I told her, I was like, listen, this is something that's, I mean, you can try doing some rehab and those sort of things, but this looks like a little more serious. And she's like insurance stuff. She's like, all right, I'll take all your advice. And then she said she did fine, and she doesn't need too much. She was a little stiff in the dorsiflexion, but didn't need a ton or anything like that. And she's back to powerlifting. Didn't go for the surgery. She was like, surgery's not an option for me. But from when I checked up with her, because I have her like every once in a while, are you in the area? If I have a student, I'm like, you guys want to see a real Taylor tilt? She'll just stop on by. We'll take a look at her. I treat her with some techniques and stuff. But I think she set the record, I think after that incident, but I can't remember for sure. But anywho, so cool story. If I ever get her again, I'll take a video. I'll make sure to put it on a Nips and Sips episode. But
stuff.
What we'll talk about, some of our techniques and those sort of things. Speaking of computers freezing, mine's kind of there we go. Everyone see this? Brandon, you can see this?
Yeah, I got you.
So Brandon's got some, I got some, it's a lot of, I think what most PTs will see is those post-cam boot or post-surgery individuals that are immobilized for a long period of time or too long. I debate Brandon, when do you think is or what grade, let's go just classic lateral ankle sprain, you think is appropriate for booting or not booting, or what do you think? Or it's also research.
Hard to say because some people just can't tolerate much and present differently. But I would say unless you're like a true grade 3 and you're not walking, or you really can't put weight bearing, which obviously we're probably going to look at the Ottawa ankle rules and see if nothing else happened. But grade 1 and 2, we didn't get into it today, and after you show your videos, I can pull up the articles real quick. But there are 2 articles out there, Josh Cleland and Julie Whitman, that talk about utilizing thrust joint manipulation early on. And there's some criteria as guidelines that they recommend, and I think that's a good starting point for most to perform a thrust joint manipulation early on and then combine it with some Therex, and these patients do very well early on. I mean, we're talking, do it that day of. I had this press fall, a high-level basketball player who's in high school, sprained his ankle, and the mom brought him in. We manipulated him. I think he maybe missed 1 game, and then he was able to go back and play. And that was just because I think they had 3 games that week. So I think it was just every other day. But he missed 1 game and was able to go back. And I definitely feel patients respond well to that manipulation early on rather than later.
I agree. I think that's huge, and especially when they've tried some things on their own and it's been a couple days, and you do a technique, and by the time they just immediately start walking, they're like, oh my God, that's that much better. That's when it was that.
Well, I hit it because it was go see the team physician. Oh, we're going to put you in a boot. You're going to miss however long. And I was like, no, like bring your son in. I'll get him playing sooner. And sure enough, we were able to. And it's just like, again, the physicians, their answer is medication or immobilization or surgery. And it's just like, come on now.
At this point,
people got to get on with their life.
Yeah, so we need to increase that percentage of how many actually make it to our doors, and then decrease the percent of reoccurrence, because immobilization or even surgery, and still some of these surgeries, maybe not so much really any sort of stabilization, but a lot of the surgeries like, oh yeah, they're fine. You don't really need anything afterwards. Well, we fixed the pathoanatomical issue. But that doesn't fix the lack of proprioception or strength or the immobility that's definitely caused from being in a boot for that long. So that doesn't fix anything, unfortunately. It lets things heal, but doesn't fix anything. And then, again, they're going out, spraining again. And they go through years of doing that, and then 30 years down the line, they need ankle fusion. It's like stupid crap like that. A lot of times, hopefully you can hear, this is a lateral posterior glide of the, I'll just let myself speak, I guess. You can't hear me.
I can't hear you. I don't know if the audience is supposed to.
Oh, you can't hear my dude talking? So if you guys can see this, I'm mobilizing the distal fibula, which is pretty common if you look at least pathoanatomically, those ligaments being stretched. In theory, with a sprain, the distal fibula can move in the anterior direction as a result. So what I'm doing is just taking that distal fibula, mobilizing it towards the ground. Can also do it with like a mobilization movement, or do a proximal. Sometimes we're locking that rotation. So this is kind of like a seesaw effect. Oh, that's good timing.
Oh, you combining there.
Yeah. Brandon, I don't know if you have some videos or anything like that. Just a couple.
I do, but I want you to, if you can explain, you gave a great pathoanatomical explanation. Can you give a neurophysiological explanation? Because I think clinicians get hung up too much on one versus the other. Exactly. And in actuality, both are probably happening, not to mention patient alliance and even placebo, nocebos, whatever you want to call it, in there as well. I think we need to have a better understanding that all of these are happening at once and not just one.
Exactly. And then I'll talk about why I picked this technique versus a talc cruel or anything like that. Using kind of my hand here, client will report to me or something of that nature that their pain is maybe localized around that lateral malleoli. I'll use a retest principle, maybe perform an AP glide at the talc cruel or PA, especially with a movement. A lot of times maybe with inversion with this. And I'll play around with a couple areas, and then I'll perform a posterior glide at the distal fibula as they're doing inversion. If it's all of a sudden it's like, wow, it doesn't hurt me to do that, because more often than not, inversion, the way they moved it, hurts them. That doesn't hurt, then that leads me to think I need to do that technique beyond the whole pathoanatomical stuff. But with me doing this mobilization, we're moving the joint, which is stimulating the mechanoreceptors locally, and that's sending that signal up through the nerves to the spinal cord to the brain, and then we're getting that that lovely discussion that you brought up before, that descending inhibitory effect, and resolving pain. And then if you want to look at pathoanatomically, you could be setting it back. But that's pretty much what's happening here. And then afterwards, I take my hands off, and I'm like, hey, can you do some inversion for me? Or I would say that, but I'm like, do that motion again. And if it's symptom free, I know I did something right. So that's kind of my thought process with that. So again, I don't do this with every ankle sprain. I don't cookie cutter it. It's just as I'm kind of working with things, maybe there's still a restriction to some dorsiflexion or inversion or those sort of things, but I'm playing around with it, seeing if that's the winning technique. But yeah.
Okay, plus there's evidence that shows mobilization improves muscle activation to that area. So
yeah, that too.
All right. So unhook there, Jer. I'll hook mine.
I'm gonna go get some juice from my laptop.
Yeah, you see this? We're up here.
Oh yeah.
So this is a subtalar, which is different than a talar cruel. So the reason this is pause, I have a video here. We actually, Jeremy and I just launched our manual therapy video membership. Check it out, but it's step by step. So the pause sections here are me talking, so you guys can set up your hands and position yourselves correctly. I'll play it one more time. So that's why there's a pause here, just for your viewers now, if anyone's watching. So the key is to have, on the subtalar, you want one hand on that calcaneus and then one hand up on the top of the foot by that talar crural joint. So you're, distracting both areas there. And then let's see if we can go to, Jay, you want me to do the talar one?
Yeah, if you got it. Usually I might do talk, like, it's pretty loud, but like with that one, yeah, like I'll do that one that you just did, and as you do it, it's just like they're pretty stiff. It's like whole body starts to move as a whole unit, and then as they're starting to get more mobile and I don't need to give it as much, you'll start to almost feel just the separation at that talar crural. Feel like almost like a little clunk versus the whole leg starts to kind of move. You can see that the joints opening up and kind of clearing out. But yeah, go ahead.
We have the cuboid, but I'm going to save that for our other episode because we're going to do one solely on cuboid syndrome. So I'll hold off on that.
That's my jam.
Sorry, Jared. You cut out just as I was finishing up the other one, or I couldn't hear you. You want me to show the talar crural one?
Yeah.
All right. See that?
Mm-hmm.
Have the patient lay supine with the foot and ankle off the edge of the table. Using the ulnar side of the And as you guys can see here, both hands are on the top of the foot with the ulnar border by the talocrural joint line. Slight pronation and distraction as needed. Apply a high velocity, low amplitude thrust in a caudal direction. So that's pretty much it. I mean, I know you and I both do mobilization movements and weight-bearing mobilizations, and even adding load to that as we progress away from, solely manual therapy and combining it so the patient could be a little more active in their approach.
Yeah, and that's something that I find is, especially if they're those more post-op ones or, post-booted ones or anything like that, especially if they're a lot of those, ankle procedures or anything like that, they're non-weight bearing for a while. So that's the time to kind of clear those things out so that they're moving right. And then I'll maybe progress that to something more functional once they're weight bearing, is those weight bearing mobilizations with movement. So it's constantly progressing as the client is progressing. I guess I can show that real quick, and then probably pretty good. This is me back in the day.
Yeah, this is the OG office.
OG office. This is before I probably had gray hair now.
Look at that, 500 views.
Yeah, I know. Can you hear this? Me speak in this?
No, I can't, but I don't know if I'm supposed to with the way the setup. But
again, this is what I'm just referencing here is, now we're starting to think, weight-bearing dorsiflexion, which we needed in running. We needed, the loading up the jump. We need it at the bottom of our squats and those sort of things. So that you may see that they have full, 10, 15 degree ankle dorsiflexion, non-weight bearing, but they have pain still in weight bearing. This is a great technique. And you can give them a band to kind of do it at home. But, those are some things. Oh yeah. He had a good, I think someone commented on that actually when we put it up, which is kind of fun.
That was great.
And, we always bust his chops at, about his calves and stuff like that. Wish he had bigger ones for that video, but hopefully, I don't know if he listens in on this podcast. But
you should have showed him how to do it, and then we could have gotten you with your soccer cap.
Oh yeah, we would have easily had probably 30,000 views if that was the case. But I guess we'll settle on 400 or so. But so that's again just some of the techniques that we do. Treat that local area, but then treating the whole person, top to bottom. But any other words of wisdom or any other things that you think there, Brandon? I think that kind of covers chronic ankle instability and just lateral ankle sprains overall.
No, I think that's it for this episode. I think we should actually, for our audience, do something on high ankle sprains and that syndesmotic. I think that's misunderstood and not covered enough. So we'll focus on that one in a
it can be a separate one.
Upcoming video or upcoming podcast today. Cool.
Awesome. Well, as Brandon alluded to before, if these manual techniques interest you or anything like that, Brandon led the way and created a whole manual therapy mentorship and video membership. So Brandon, I don't know if you want to talk a little bit about that before we wrap up.
Yeah, sure. The membership is it's actually just a one-time cost, but it's just under 100 videos right now. We're going to add more to it, but all the techniques are manual therapy geared towards the spine and the extremities. Like I said, just under 100. And then we have an extension of that. You guys can upgrade to a mentorship, which basically includes the videos as well as a private Facebook group chat and 2 virtual calls a month with myself, Jeremy, and Dr. Kyle Feldman, who will be on this show in the next couple weeks as well as access to over 600 fellowship level articles. So you'll be able to pick our brains. We'll guide you through patient cases, anything within the profession, whether it's legislative stuff or, career oriented things, or even opening a business, as all 3 of us are owners of our own business. So hopefully we have compiled a nice, well-rounded mentorship for you guys. And right now it's only $29.99 a month, but that price will be going up. So hopefully you guys hop into early bird special, and we can help you out and meet you as well.
Awesome. So yeah, if you're one of those people that are, you're kind of using only 2 techniques per joint, which I think I started off my career as, it's an awesome thing just to, sign up for this stuff, pick up on some new skills, have access to it. So it's just like, man, I'm working with somebody and what I'm doing is not working, exercises, are so, oh, let me at least hit this. Let me look up something real quick and, have access to a lot more techniques. Yeah.
I think the biggest thing too is I know there's those Facebook groups like networking and doctor, student, physical therapists. And, a lot of people post questions there, but then you get, 100 answers back and people contradict each other, and there's more arguing and fighting. And I've read some of the responses of people, and I'm more confused than anything. So I can only imagine somebody who doesn't have that training, or someone who's a new grad trying to figure it out, and they're getting told all this stuff. At least here you have 3 fellowship level trained PTs, all gone through residencies, all have the same philosophy, but have gone through different programs as well. So you get the experience and the insight to 3 different programs, and also how when you reach that level, there's a lot of similarity as well. So we won't be arguing against each other either. So I think that'll be really beneficial, especially for those newer grads.
Yeah, I think we've on this show had maybe 2-3 times where we didn't exactly see eye to eye, but wasn't necessarily bad because again, more of our training. Not a bad thing, but it was fruitful. Gave some good ideas, but awesome. So thanks for listening, everyone. If you want to reach out to us, I'm at The Decent Doctor and at Trifecta Therapeutics. Oh, and Manips and Sips, of course, is on Facebook and Instagram. Brandon's at Think Like a Fellow and at Pursue PT Now. Thanks for listening, everyone, and cheers.
Good.